Hi, everyone. This is Kate Berry, CEO of the National eHealth Collaborative. And on behalf of our Board of Directors, I'd like to welcome everyone to this program. We're very, very excited to have nearly all of our 12 HIE leaders that are profiled in a soon-to-be-released report with us today, some of whom are here today in the room, and others who are on the phone with us. And welcome to everyone who is watching the live webcast. So I would just like to thank also Jason Kunzman from ONC for joining us. We're delighted to have him. He's a member of the Beacon team. Well, shortly we'll be doing introductions of all of our HIE leaders that are participating. But I just want to do just some very, very brief opening remarks. First of all, I think we can all pretty much agree that HIE sustainability is an ongoing challenge for everyone. This is a large reason, one of the big reasons why NEHC commissioned a study of some of the very most successful health information exchange organizations in the country so that we can learn from those that are leading the way. This roundtable event is really a preview of a report that's going to be released very soon, which is entitled HIE Success Stories Revealed, Lessons from the Leaders. So this is going to be a preview conversation, and hopefully we'll be able to touch on sustainability models, touch on how these organizations can offer some guidance and insight for emerging health information exchanges, and begin to create a roadmap for national health information exchange. So we're very, very delighted to have everyone with us today. The plan today is to really just start a conversation. We're going to have a pretty informal discussion and hopefully get some of these interesting issues on the table and discussed among our leaders, touching on, key dimensions for success, as well as some of the key challenges and how they're being overcome. So with that, I would like to really kick off the discussion. And first, what I'd like to ask all of our guests to do, our HIE leaders to do, is to spend, let's say, and we have a lot of people in a fixed amount of time. We have about 90 minutes. But I'd like to ask each of you to do a brief personal introduction, and then give us, 3 to 4 minutes on introducing your organization, your scope of services.
The caller has joined the conference.
Your role in the community, and briefly what your sustainability model is. So with that, I'm going to start with the folks in the room, and I would like to ask Tom Fritz from Inland Northwest Health to just start with an introduction and an overview of your organization.
Thank you, Kate. My name is Tom Fritz. I'm the Chief Executive for Inland Northwest Health Services. We're a not-for-profit 501c3 kind of hospital-based company in Spokane, Washington. We've been in existence since 1994, and we came into existence as a result of our competitive hospitals actually trying to do some things in a collaborative way, where we ended up taking over a number of lines of services that were kind of difficult to manage and difficult to sustain in a competitive mode. So our job was to be kind of a neutral party and be able to keep those services available for our community and our region as a whole. One of the things that we did develop about 13 years ago was actually kind of a shared services model for information technology, which has kind of led to the development of our health information exchange. We were somewhat criticized at first when we did that, and that we, at the time, a lot of the providers really used IT as a competitive product. We selected to do some things collectively, and ultimately then significantly reduced our costs. So as an example, in our community we had 5 acute care hospitals. We reduced our data centers from 5 to 4. So we immediately started saving millions of dollars worth of infrastructure costs, and we also agreed to standardize a number of our hospital information systems, and really did that in a way that, again, saved us money and really started to create some value for us. We partnered with our physicians in the community. That was probably one of the most important things that we did in terms of really helping determine the value of our system. In fact, when we first started it, I did an analysis for all of our hospitals that showed that we were spending millions of dollars, but no doctors were ever looking at the system. I mean, there's multiple sign-ons, there were all these things that made it very difficult for them. And so we all thought we were doing great work, but it really had no value whatsoever. So over time, what we've been able to do is, because of this model, we have about 40 hospitals now in our region that outsource their information technology to us, and we do that as a shared service model. It's created a great opportunity for us in terms of sustainability, in that we have consistent revenue coming in and everybody takes a share of what they use of the system. And so our expectations really of managing the hospitals is that we continue to do things that create value-added service. And so for us, the sustainability issue is one that we have to do more with less. And especially with the economics the way they are today, we have to continue to do things that help our physicians and our hospitals be more efficient and be able to get greater value out of the system that we've created. And that's kind of the direction that we're taking. I think we'll see us adding on more kinds of services onto our health information exchange, such as data analytics, other kinds of things, report cards, and clearly we stay away from things like transaction fees and even membership fees. We really do it in a different type of business model. So I think that's my 4 to 5 minutes.
Thank you, Tom. And Russ, would you like to go next, please?
Great. Thanks, Kate. Thank you for having us here. I'm Russ Thomas. I'm the President and Chief Operating Officer of Availity. Been with Availity since 2008. Prior to that, I was the Chief Executive Officer of a company called Gold Standard, which is a clinical knowledge-based business focused particularly in pharmacy information, pharmacy knowledge bases. We sold that business to Reed Elsevier in 2006, and I joined Availity in 2008. Availity is interesting listening to Tom. Availity is a little different model. First and foremost, we're a health information network. So what we really do is bring stakeholders together within our network. So today we have over 200,000 active physician users of our system across the country. We have over 1,000 health plans that use our platform and thousands of U.S. hospitals as well. So in 2011, we'll transact over 1 billion transactions across our network. We've historically been focused in administrative transactions, so the kind of electronic events, electronic activity that physicians and health plans have to interact with each other all day, every day. So everything from basic eligibility and benefit transactions to claim transactions, and then moving upstream in the value chain to things like member estimation, so that in real time a physician can determine just how much a patient owes at the point of service. And now ultimately moving into clinical transactions. And one of our core principles is that we take a very holistic approach to health information. We believe that it's important, and one of the reasons for our success has been that we combine transaction types and information types across one network. So at the same time, we tell a physician office whether a patient is eligible for benefits, we also share access to clinical information, what we call our Availity Care Profile, which is essentially our electronic health record. We found that by driving information across that common framework into the workflow, one of our mantras is serve the physician where and how they work. We found that by driving that information across a common framework into their workflow, we get adoption and utilization of a lot of different types of capabilities. Our business model has historically been transaction fee driven. We charge specifically health plans for the transactions that we serve up across our network. So every time we run an eligibility and benefit transaction or a claim transaction or even our clinical transactions, we are charging a transaction fee to the health plans. Historically, the business has been funded exclusively by health plan revenues. Last year, we acquired a business some of you may be familiar with called RealMed. It's a revenue cycle management business focused primarily in the ambulatory space. And that business is actually both a health plan sponsored as well as a physician subscription fee driven business, and frankly is about 50-50 in terms of the revenue mix, physician monthly subscriptions and health plan revenue. So we found, I think, a fairly interesting revenue model, sustainability model that lets us drive value across really all sectors of the value chain, from health plan to physician to our vendor partners. We have over 400 vendor partners that use our network to transact between physicians and health plans. And those are historically practice management systems that connect to us. But now we've started implementing with electronic medical records vendors as well, so that, again, at the same time that we're delivering up that administrative information that physicians need to run their business, we're also leveraging that platform to deliver clinical information as well. Just a little bit on background, we're a for-profit business. We are a joint venture of 5 large health plans. Our joint venture partners are Blue Cross Blue Shield of Florida, Humana, WellPoint, HCSC, Healthcare Service Corp., which is Blue Cross of Texas, Oklahoma, Illinois, and New Mexico, and Blue Cross Blue Shield of Minnesota. And with me today, I have to introduce Kathleen Herzog, who is our VP of Marketing and Communications, and her primary responsibility is keeping me straight. So I keep looking at her saying, am I saying what I'm supposed to say, Kathleen? And she's giving me the head nod here. So that's a little bit about us. I'll be glad to talk more about it as we go through it. And again, thank you for having us with you today. It's a pleasure to be here.
Thank you, Russ. Dr. Blair?
Yeah, thanks, Kate, for inviting me, and I'm happy to be here. I'm from the Hudson Valley. I've been a practicing physician for 15 years in academic private practice, left that 5 years ago because this project's finally completely consumed all of my time. But I'll talk about not just the organizations that I'm part of, but the Hudson Valley Initiative in general, because it really has been driven and has succeeded because of 3 organizations. I'm with Taconic IPA, a 5,000 physician independent practice association in the Hudson Valley. I also run MedAllies, a health information service provider that is located in the Hudson Valley, there to help implement and support health information technology. And then there's another organization run by Susan Stewart, which is Think, which originally started as a RIO, but really has evolved to a regional organization that really has, I think, expertise in being able to extract from the various stakeholders, healthcare stakeholders, and within stakeholder groups, leadership to convene and really move the community with a kind of governance structure that gets small wins, credibility, and achieves something that's hard to do in an open community. There's no IDN in the Hudson Valley. Hundreds of practices, from solo practitioners to 200, 250 doctor groups, federally qualified health centers, 20 or so hospitals, 6 or 7 health plans that make up the bulk of the commercial care. So it's, I think, typical of a lot of communities without an IDN, and Think has been able to get some of the principles of governance across an open community. I think that's a lot of the success. The IPA, about 10 years ago, started to focus just on quality initiatives, and over the last several years has really been focused on patient-centered medical home, practice transformation. The MedAllies was really started to help providers implement and truly utilize for better clinical care health information technology. So really, I think it has turned out to be the prototypical regional extension center. The workforce, there's probably about 40 people that maintain and help implement and support provider practices. So Those three groups, if you look at what we've done, we touched probably about 2,000 providers in the Hudson Valley. I think most, if not all of those, they're all on certified electronic health records, and I would say that most, if not all, will make meaningful use in 2011. Probably about 1,500 of them use the health information exchange that we developed. A couple of counties, it's not fully, the hospitals are not fully integrated yet, so it's not used as much there. In terms of patient-centered medical home and transformation, of our primary care providers, of those 2,000, about half of them, over 300, we were able to get to level 3 NCQA recognition in about an 18-month period. So clearly they're really using their electronic health records. There is, as they've become more and more sophisticated and with more robust usage, there's been a screaming need for connectivity between providers. We're very interested in the direct project along that line. Our health information exchange, we believe, complements that. We see it used differently. And then lastly, we are entering into a project with Geisinger, taking their Proven Health Navigator program, which is really robust patient-centered medical home, and using embedded care managers. So we've had several that have been out training at Geisinger. We've been working on the program for about 6 months. Those embedded care managers will be going into play July 1st, and they will be targeted at the most expensive, most complex patients, and we've chosen our best performing patient-centered medical home practices for that, and we're very excited about that. Lastly, Think runs a multi-payer value-based purchasing program. The 6 health plans and 1 large employer in the region are participate in that. I think last year they paid out about $1.5 million to some of the medical home practices. That'll probably double this year. And they're wrapping the embedded care manager program into that project.
Thank you, John. And Kimberly, can you tell us a little bit about Sandlot, please?
Sure. My name is Kimberly Elise. I'm the Chief Executive Officer of Sandlot, and I'm relatively new to the company, actually the past couple of weeks. So previously, I had co-founded a company called Empower Systems, which is clinical documentation. Started out as a best-of-breed emergency department product, and we built an ambulatory and full-blown inpatient. So, as a best-of-breed vendor, I get the need for connectivity, and I'm excited about where HIE is going. So Sandlot Connect is a comprehensive HIE with all the services that surround it. So we're really trying to target hospitals, health plans, IPAs in various stages of adoption. We get that not everybody's ready to move. We're actively developing products and services to reach people in the various phases of growth. And one thing we do, I think, a little different is we actively help with EMR adoption. And so I think one of our points of uniqueness in the market is that we're able to leverage our active physician usership. So we're a wholly owned subsidiary of NTSP, which is North Texas Specialty Physicians. And that is a family and multi-specialty practice company that manages 30,000 capitated lives. So we, part of our model is certainly to help them, as also our biggest client, realize cost savings and enhance patient care. But with that comes something that's very great, which is very involved and engaged practicing physicians using our product every day. 65,000 clinical transactions daily. So it's really, kind of a luxury that we enjoy to have that input. And that's very key to our mission and our growth, which is that active physician usership and a great user experience that really focuses on, user friendliness. We really look at clinical workflow. Our plan is certainly to expand our footprint in the Dallas-Fort Worth area, but also, to seek the challenges and opportunities in other markets. And Along with that, we're actively developing some new products. Now that we have all this data, there's, obviously everyone's been talking about analytics, and we're looking to really create something with value that does merge operational clinical data with point of care. So the ability to really look proactively and identify patients who might be at risk, to do decision support at the point of care, and then to use core measures like PQRI and HEDIS to do the historical reporting that's so important. Thanks.
Thank you, Kimberly. So now I'd like to turn to our participants on the phone, and I want to start by calling on Michael Matthews. Michael, are you with us?
I am, Kate. Thank you. Greetings, everyone. It is my pleasure to join this esteemed panel, and I thank you, National eHealth Collaborative, for putting together this significant project. I think there are a lot of successful stories in health information exchange that need to be better told, and you're playing a great role in doing that. I'll give you a few data points on Med Virginia. We've been in operation with our health information exchange since January of 2006. At this point, we have about 1.5 million records in our clinical data repository, as well as an increasing number of federated nodes on our system as well. There are a couple of things I would like to highlight. Certainly, a lot of the attributes that the others on the panel have mentioned are great critical success factors. I'd like to point out the importance of the Nationwide Health Information Network and our participation in that as far as meeting our strategic goals and objectives. Some of you may be aware that Med Virginia was the first to go live into production through a partnership with the Social Security Administration, and that particular use case has been well chronicled. There was an independent case study on our work with the SSA and the value proposition, not only to the patients who are going through a disability claims application process, but also to the providers and to SSA itself. So we're very pleased to have been part of that initial work. Also, very pleased and proud to participate in the virtual lifetime electronic record, along with our colleagues from the VA and Department of Defense. That has been one of the most gratifying initiatives I've worked on in my 31 years in healthcare. Our project in Hampton Roads region, Virginia, went live in October and has now rolled into the Richmond area as well. Just from a mission standpoint, we have an ongoing key message point around leaving no patient and no provider behind. And so for us, being able to address the needs of the chronically ill, the disabled, and our wounded warriors ranks right up at the top of our strategic imperatives. And through the partnerships that we've had regionally as well as nationally, I feel like we've made a lot of strides. So, again, it's exciting to be part of this process. I get a lot of visibility in my role on the Nationwide Health Information Network Coordinating Committee about the fine efforts that are going on around the country. And again, Kate, thanks to you and NeHC for leading forth this charge.
Thank you very much, Michael. Dev Culver, are you with us?
I am, Kate. Thank you very much. Hi, I'm Dev Culver. I'm the Chief Executive Officer for Health InfoNet, which is a private 501c3 organization in the state of Maine. We are the designated statewide health exchange for the state. Health InfoNet is a stakeholder organization that was created in 2005. It represents the 5 primary stakeholder groups, including consumers, providers, government, business, and payers. At this time, we've been operational for just about 3 years in terms of actually supporting clinical care. We have just about 67% of the population of the state is in the database. That represents about 900,000 people, give or take a little, out of 1.3 million. We are connected at this time to 16 hospitals and 4 group practices, and are growing this year by another 8 hospitals, which will get us up to basically the vast majority of care delivered in the state, because many of these hospitals in Maine are actually the anchor for the primary care structure in the state, too. So when you get the hospital, you also get the primary care physicians in the structure. We are currently based on a sustainability model that is both part subscription and part contract. we do have a fair bit of federal money flowing through us right now as a result of the HITECH Act and the HIE grant program. But that money will soon disappear, and so our focus in sustainability is now moving over into some direct value services. We have 3 separate ACO efforts going in the state, and we are remaining neutral and trying to be a critical information provider, both in the real-time care component and in the near real-time and analytic component for supporting analyses. We're working with an academic institution right now to build out and finalize a predictive modeling structure that will enhance some of the ability to look at populations both from a cost and clinical outcome perspective. And we're actively engaged in one of the 17 Beacon Community Grants. We're the primary contractor to that grant, connecting the community of Bangor, Maine, to focus on 4 chronic care conditions. That project is going along terrifically. We brought up the other hospital in town a couple months back, and we already had 75% of the people in the database that were registering into that organization. So there's a very high probability we're going to see some real impact. That is, as was mentioned earlier with the conic, that is a care management approach where each of the organizations is committed to providing clinical support through dedicated care managers. They're using the exchange as the basic vehicle to manage on common standards within those 4 areas of chronic care. And the exchange is really serving as the vehicle to connect both the information but also provide some of the automated interpretation of that data. Going forward, our state plan is to have all hospitals connected by 2015. I think we'll actually be there by 2014, and to have 80% of the provider community connected by 2015. Our growth objective really will be the database itself. Maine is unique in one respect in that it's one of only 6 states in the nation right now that has an all-payer claims database. So the process of being able to marry up the claim with the clinical activity is coming along now, along with that analytic effort. We're also looking into some other opportunities. For example, one of the value-add propositions is to have the exchange become the prescription medication program for substance abuse in the state in terms of supporting what is now an independent and separate portal strategy by bringing that into the exchange. Not only do you get the added advantage of having the other clinical data, but you get another advantage, which is in addition to seeing prescriptions that may be signs of medication shopping.
The caller
Tom Dees
has left the conference.
You also get to see the shopping behavior while it's occurring as a result of the registration and office visit information that you have. So we continue to look for opportunities like that. One of the projects we're going to connect up with here this year involves the patient-centered medical home initiative in the state. We're one of 8 states funded through CMS for that right now, and we're going to look at an ED visit notification process with follow-up tools so that we can begin to impact on what is a very expensive and high-volume transaction activity in the state, which is overuse of our emergency room structures. So that's basically what we are.
Very good. Thank you, Dev. Next, I'd like to call on Tim Cromwell. Are you with us on the phone, Tim?
Yes, Kate, I'm with you. Can you hear me okay?
Yes, we can.
Okay, thank you, and thanks for the invitation to present today. I'm Tim Cromwell. I'm the Director of Standards and Interoperability for the Department of Veterans Affairs, Veterans Health Administration, and I am also leading the health information exchange activities with the private sector, including the Nationwide Health Information Network and the VELER Project, Virtual Lifetime Electronic Record. Many of you know the VA, Veterans Health Administration, but just in quick review, VA serves over 6 million enrolled veterans for health care. And we have more than 1,200 points of care throughout the country. We employ more than 250,000 clinicians and clinician support type activities. VA has a very robust electronic health record with wide adoption by all of our clinicians, and it's regarded, our CPRS product is regarded as a tool in clinical care. The computer is not a luxury anymore. It's a part of our everyday clinical practice. There's a little bit of difference between the Department of Veterans Affairs and the other HIEs who presented today, starting with the sustainability model. our sustainability model is based on federal tax dollars. Our driver for interoperability is our veterans, and many of whom receive some portion of their care from the private sector, from private sector hospitals that are represented by health information exchanges that are on this panel. And so we take the driver from our veterans for better coordination of care with the private sector very seriously, and it really drives our activities with the Nationwide Health Information Network, with participating in the DIRECT project, and all of the activities wherein we can provide information from our systems to private sector clinicians and get information in support of veterans from private sector clinicians. We are actively engaged in the Nationwide Health Information Network exchange activities. By the end of September of this year, we will have be interoperable with 11 sites with 11 different health information exchanges throughout the country. By next year, about this time, we expect to go in a national deployment where, as a member of the Nationwide Health Information Network, any other health information exchange will be able to get veterans' data, provided the veteran has provided the authorization. We are an opt-out shop, meaning that we are going to ask every veteran if they want to share information with the Nationwide Health Information Network, and we will honor their consent directive. If they don't want to share information with the NHIN, we at this moment do not have a break the glass scenario. We will not share information with the Nationwide Health Information Network partners, but our systems are being built right now to support the opt-in characteristics. I'll stop there, Kate.
Thank you, Tim. Next, I'd like to call on Mark Jones.
Kate, thank you very much, and appreciate the ability for all of us to get together and talk about our commonalities here, because certainly we have a tremendous variety of projects, and yet I think we all share some issues about sustainability and governance. SmartNet is really the outcropping of a transforming healthcare through HIT grant from AHRQ in 2005 and 6. And to make a very long story short, it evolved into an HIE utility company whose functions were to build multiple self-governed, sustainable networks that could also share data within Oklahoma and also outside of Oklahoma. To date, we have created 8 different self-sustaining networks that are governed within their own structures. 4 are regional networks. There's a hospital network in Oklahoma City with 13 very large hospitals. Norman Physician Hospital Organization is one of the leading technology projects in the country. It is a part of a challenge grant about transitions of care and involves a local network, an API for prevention and SmartNet interoperability. There's a rural safety net network. There's a urban safety net network. There is SmartNet Direct, which is an open network for anybody in Oklahoma who doesn't have a network yet. The Oklahoma State Medical Association for all physicians in the state. The Oklahoma Association of Optometric Physicians, which is all the state's optometrists. And our latest network is an intertribal network of the state's 4 largest tribes. All of these networks participate together in a common effort as well as their own effort. So as an aggregate, they now have 2.3 million patients, which is about 2/3 of the population of Oklahoma, about 15 million diagnoses. Data is coming in from 64 cities and all 77 counties. We also played a very important role for 90 days in bringing up a project in Tulsa, which utilized the planning effort to become a beacon community. So the networks together individually can choose their own members, services, do reports. They're all nonprofit, set prices, training, and use their own technology or borrow ours if they don't want to go through that process. In the middle is the SmartNet governance process, which is members of each network sit on a common management system. That common management system has evolved over 5 years, almost cost $5 million for the resources for it. So the resources they share, so they don't have to reinvent the wheel, are a common network of networks management system. There are 14 interoperable legal documents for various phases of development, 27 security policies, common default technology. We also help with EMPI, training the trainers, and literally 20 other services. The key to it is something that sort of evolved in the process of building our network. We had to report to ARC how we built it, and watching ourselves do it, we developed some tools that all these networks are able to use. So, for instance, the planning process requires a meeting of the governance groups across all the members for a potential new network. They need to resolve 15 issues we've identified. There are 14 legal documents to study, 27 security policies, clinical benefits, individual ROIs, and specific issues to each network. So there's a commonality in the middle where they share a lot of resources. They're also very independent to do what they think that they need to do. We are a participant as one of the nation's direct projects, so we're standing up a direct secure messaging process right now. We're very interested in utilizing this network of networks to build something I think one of our projects said earlier, which is essentially a small-town self-governed network. We think that there's an impact grant out there that would help us to implement multiple efforts where the citizens in each small town could actually help drive its own healthcare system. So we're very interested in that. The issues around sustainability, primarily subscription, but we think because these networks are very close to their users, represented by the users themselves, the value becomes so apparent from being in such a close set of relationships that it makes sense to continue that. We think the trust is really big. For instance, the SmartNet Management Committee meeting is available on statewide television through the Oklahoma State Health Department, and the costs are low, around $30 for a physician. So I think with that, I would just simply end by saying where I think we're going is to ACOs, to medical homes. A lot of folks are using this infrastructure to apply for new grants, PHRs, and certain population analytics. So, Kate, thank you very much for asking us in, and we very much appreciate being able to work with the group here.
Thank you, Mark. Before we go to the rest of our participants on the phone, I do want to just briefly introduce Michael Solomon with Point of Care Partners, who is one of the authors of the report, who helped NEHC kind of pull together the profiles and the report that we'll be releasing very shortly. And I want to also, pause here and introduce Claudia Williams and Jason Kunzman, who have joined us from ONC, and offer them a quick chance to make an observation or two before we have the overview from the remaining HIE leaders. Jason, you want to?
Thank you, Kate. I have the coolest job in the whole world because I get to work with 17 of the hippest communities across the country, many of which are represented on the panel today, and working diligently to establish robust health information exchange capacity. It's not easy work. We've got folks that are ranging in sort of the status of their journey from folks in Tulsa that Mark mentioned, where they're looking to initially stand up a health information exchange, and folks like Tom out there in Washington who have been at this for a long time. So the set of challenges is, if you've seen one Beacon community or if you've seen one health information exchange, I think you've seen one health information exchange. We know that healthcare is local. A lot of the challenges are unique to each of the communities that we're working with. I think it's great. I love the level of conversation around sort of the ancillary services and products that folks are looking to sort of hang off of their health information exchanges, from business analytics, community-wide clinical decision support tools, and the like. So I'm very encouraged by the utility of the infrastructure that is being laid out across the country. I think we're headed in the right direction. It's going to take a while, though, for us to get to where we eventually want to be. But again, it's exciting work, and for whatever it's worth, I commend all of you on the panel and those across the country that are looking to utilize this sort of connectivity to improve the quality and reduce the cost of our overall system. Claudia?
Thanks. I think a couple of us actually came over here appropriately from the summit that's happening across town on ACOs. I know John just spoke there, which I think is an appropriate, I don't think a day goes by that there's not some kind of a summit or effort to try to parse and figure out these linkages between the healthcare transformation agenda we're all looking at and the IT infrastructure that we are also in the middle of trying to implement. I'd also like to introduce my colleague Chris Muir, who's joining us here. I wanted to just reflect, sort of thank you for the lessons you've provided today and tell you a little bit about how we're trying to take some of those lessons forward in the HIE program. And we can always use your feedback about whether we're doing it well or not and how we could do it better. So one theme came through really, really strongly to me, and I think it was even mentioned by somebody on the phone specifically, which is being close to your users. Now, as a state, it's often hard to figure out what that means. But one piece of advice and guidance and work we've been doing with our grantees is to say, first of all, have users, like have a conception of what you're trying to accomplish and for whom and the value you're bringing, and be able to track whether people are actually using that service and sort of buying the value. So that it's we've all seen models where you launch some cool IT thing. I think somebody over here even mentioned it. You're really excited about it, and at the end of the day, no one's using it for nothing. So one of the pieces of guidance we've really tried to give to folks is provide value in the near term and make sure they're actual users finding value to do the kinds of care jobs we're asking them to do for meaningful use. So a real focus on meaningful use, a real focus not on some 10-year goal, but doing something this year that can provide value to folks and seeing if people are actually adopting and using that as a metric for success. I think another theme I heard, and I think John particularly brought this out, is, actually several of you did, even within a community that's adopted sort of a particular approach to HIE or HIT, people are in different places. And we are not going to be able to offer a model that gives, your prefix for everything you need to do, that everyone's just going to simply purchase and say, done with that. So we may need to work with folks who are just barely able to, launch their EHR systems and need a really simple, scalable way to send a result to somebody or send a care summary. And direct may be the best way to do that. We're in the middle of that grand experiment. Other folks are far along in understanding how they're using their systems, are really using, let's say, a query-based model that's working great for them. And again, not only do you have people in different places, but you have different use cases to satisfy. And so I think I love hearing about how, you're moving forward on several fronts. You're not assuming that everyone is consuming exactly the same thing, but you're trying to figure out ways that those different strategies can be super aligned and thoughtful and, again, deliver value to folks on the ground. I think a final thought I have, it's just more of a reflection than a conclusion, is it's true, healthcare is local. I mean, at the same time, we know that a lot of exchanges are occurring that's not geographically based. But there, especially when we start to think about things like analytics, aggregating data, having consumers trust the system, having providers trust the system to be able to deliver value to them, being able to look across the table and see your other partners and know what your expectations are for them, it does feel very strongly to me like that's going to be a local and regional effort. I think states can play a huge role in creating the framework for that trust. And I know, like in Texas, where there are a set of expectations for interoperability and privacy that all the local HIEs and HIOs to get grant funding need to provide. But I think there's something very critical and important about a regional and local effort, especially when we start looking at things like medical homes and ACOs and other efforts. So another thing that we've strongly messaged to our grantees is where there are local assets, like local exchange capabilities getting developed, or maybe they're nascent and they need to get across the line, support those efforts. Find ways to do that. That may look different in different states. It may be a matter of coming up with common infrastructure like directories or EMPI that folks can share. It may mean having a common set of policies that can assure trust. It may mean actual grant funding, as Indiana's doing for, getting to rural providers and CHCs, even though they have really very well developed exchange capabilities. So I think that recognition that, especially when we're talking about some of these, and I think there's going to be a role for state in analytics, et cetera, but I think there's going to be a comfort level with data aggregation that's a little closer to patient care that we're probably seeing in Beacons and other communities that can be very well served by the work all of you are doing. And I think the same can be said for the VA, for a care delivery system that people can touch and feel and see. So I think finding ways to help support that kind of analytic capability getting developed somewhat close to the patient and where the patient gets care will be really successful. So I just really thank you for your work. And thank you for both the progress you've made and also the ways in which I said to Mark Overhage when he went to Siemens, I said, I'm really sad that you've just, every rock you've unturned, you've found more little problems and just solved them for the rest of us. So you guys are in that work of picking up the boulders and building the road, and along the way you find all kinds of issues that all of us are going to be facing, and you've just tackled and solved a whole bunch of them, and then you've come back to the table and said, but these ones we really need your help with. So we're there both to thank you for that rock uncovering work you've done, but also to be a forum where you can bring the problems that are still vexing you.
Thank you so much, Claudia and Jason and Chris, for being with us. I think it's a really important collaboration and conversation to have together. Next, I wanted to see if Dick Thompson is with us on the phone. I know he has a talk he has to deliver in a little while. Dick, are you with us? Doesn't sound okay. How about Alan from Big Bend? Alan, are you with us?
I am.
Wonderful.
Alan Byington with Big Bend Rio in Florida. We began in early 2005. I'm a founding board member and executive director. And we started from scratch as there were no shrink wrap products for community-wide HIE in 2005. And we started with a clean slate and looked at interconnecting the disparate system across an entire community. Like other communities, we don't have a significant IDN presence here. So it's pretty much one-off providers with a medical trading area population of about 700,000 in 7 surrounding counties, predominantly very rural, up in the panhandle of Florida. And we architected a system that went into test production in late 2007, pretty full production in 2008. We now have records for over 70% of that population, over 500,000 unique patients in the system. We currently process about 700,000 HL7 messages a month, with about 35,000 user queries a month. So as discussed previously, we've got the tools now to know that the infrastructure is being used in a meaningful way and that there is value bringing those users back to the system repetitively month after month from about 65 connected offices and facilities, predominantly here in the urban community. With relative success in the urban area, we're now beginning to spread out and begin to pull in those rural counties, and most of them have critical access hospitals in them, beginning to outreach, and as they emerge with their electronic capability, interfacing with them to begin to share data bidirectionally across the entire medical trading area. So we've gone through the pains and picking those boulders up in the early days in developing the legal and social infrastructure. Workflow integration, as has been mentioned before, is extremely critical. Workflow memory is very strong in this industry. Workflow disruption is very frowned upon, as we all know. So as this system has matured over the last couple of years, because of our access to the community stakeholders and the workflow that they deal with on a daily basis, we were able to tailor the capability of the HIE application to fit within specific workflow issues, which has been very instrumental to the success that we've had over time, creating that common framework of governance and legal infrastructure and security, much like everybody else has had to deal with and is still dealing with. Still remains a little challenging, but much easier than, of course, when we first started. We have about 16 board members, so we're provider-driven and provider-governed here in the community from day one. That's been a significant asset and a tool, is to have the decision makers that have the repositories of data at the table throughout the process to make that data available when everything was in place and it was appropriate for them from their comfort level, both from a technology and security standpoint. We are at the point now with enough data flowing to begin to really look at the data that we're able to collect. Some of us are obviously very aware, but there's limited data elements that we're able to extract from the current EMR systems that are all pretty much pre-certified. And from the data that we're able to collect, what are the analytics that we can run to provide, what information that's a useful tool? Just having access to the user trends and the business trends happening on the HIE is a valuable tool. We're able to look at who's sending the referrals. We're able to look at the response times of the referrals. So if a primary care provider is sending electronic referrals, but yet the specialists aren't responding at an appropriate time, we're able to identify that very quickly and work out any issues between the providers that may arise to help enhance the response times and improve the workflow efficiencies, which ultimately gets the patient seen faster and less time in the waiting room. So we are obviously, like everyone else, emerging in that area to continue to drive value to the system. We are a pure subscriber-based model from a sustainability standpoint. It's a per doc, per month fee that covers up to 3 of their extenders, and then the hospital is a per bed fee for the hospital contribution to the effort. And we're at the point now, we're having conversations with several other communities in our state to help provide lessons learned and best practice with what's come out of this community in other areas across the state. A big concern of mine personally, having been in this space from its infancy, is here in Florida, being one of the larger states, obviously we're going to get some EHR incentive money, and we've gotten some regional extension money, and the state's got the cooperative agreement funding, but there's virtually no funding for the local HIE infrastructure that's required to participate with the Florida network as it emerges, as well as the NHIN network as it continues to grow and emerge and become useful. So we talk a lot about the focus on the local healthcare being local, and that's been our mantra from day one, is that it is very local and that we need to focus on exchanging data across the street before we do it across the state, or across the country. But there's a significant paralyzation in part due to the funding for the local HIE infrastructure, and then sort of the unknown of what's really going to emerge from the state network, and then obviously from where will NHIN ultimately end up. So that's a continual barrier that we are dealing with in these other communities that fortunately we were able to overcome here in Tallahassee. But as we reach out, assisting these other communities, it's really difficult, especially in the larger metropolitan areas, to get collective consensus from enough stakeholders that are willing to come to the table and put funding in place with all the unknowns that are still on the road ahead. Of course, we continue to work towards that goal, but that's a big issue that we see going forward is how do we fund the local infrastructure, or how do we incentivize those stakeholders that are actually will be carrying the burden of that funding as it currently stands out of their local investment. But we are proud to be where we are. We're pleased, Kate, to be involved in this effort, and appreciate your time and effort to bring us all together to highlight some of the issues that we all face and how we can do it better and quicker, faster.
Thank you, Alan. Keith Hepp with HealthBridge, are you with us?
I am. Thanks much, Kate. Appreciate the opportunity to address everyone here. It's always going near the last because everything's already been said. So I'll try to cover some things that are unique about what we did. We've actually been around since '97, and we've got a history in this region, the Cincinnati regions in the Southwest Ohio corner. So there's been discussions of Availity with Russ. That's a national endeavor. We have states and multi-states with inland and others, and we're a regional. We deal in Kentucky, Ohio, and Indiana. And to Claudia's comments, there's a role for all of us in all these different pieces, and we've been electronic since '97. We've had a community-wide messaging system since 2000, and in our community, if you have your own EHR, terrific. We feed 30 different EHRs. If you don't, then we've got a lightweight, meaningful use package that physicians can use, so that so if you're in this region, you only get information one way, and it's electronic, and 97% of all results are electronic today. So we've in our journey, we've first become electronic, and we're also in every region is a little bit different. And in our region, independence is valued, and so we've built some infrastructure here, and then we connect to other independent HIEs as well. So Health Link in Bloomington and CCHIE in Springfield, and the Dayton region goes live in next month, and in total we'll have 50 hospitals, and also in Northeast Kentucky, Rio. So we'll have 50 hospitals, 7,500 physicians across about 30 different sending organizations. So we started connecting. We've gotten electronic, and to Claudia's point, you need to meet people where they are. So we try to have as many different ways to meet people where they are in their electronic journey, and move them to full, meaningful use. So we've been profitable since 2004. We also have a number of different products that we leverage the core in order to get a higher margin, break even on connectivity, and add additional products and services on top of it. In our journey, we really didn't go for grants until ARA came out, and most grants were not along the path of where we were heading as far as our business plan goes. But with the advent of ARA and some of the products or some of the priorities of ONC were dead in our path of where we were going. And so we've gone from a non-grant entity to using, we're an REC for our region. We participated in the next phase after Med Virginia in the SSA program, and HIE with IBM. We're also a Beacon site. And all these we are viewing as capital for the next phase of development. We've already got eligibility, electronic lab ordering. We support PCMH. We have registries. But we're using Beacon dollars, similar to other communities, in order to take the infrastructure to a different level that will then allow us to do, instead of light analytics, do full analytics. So we're taking advantage of all the great programs that ONC has out there, and we really view that as our value proposition going forward, because with NHIN Direct, which we're also participating in, as well as other just general transport of data, that piece is going down, and the value long-term is in supporting other community initiatives that are addressing the triple aim. So in our Beacon work, we're very focused on we're very focused on asthma and diabetes, but we're really looking at that infrastructure once we move the dial, that we move it towards an ACO kind of environment where competitive ACOs can be on one platform, but it dramatically reduces the cost of participating in an ACO by having one analytics package, and as Claudia said, have the folks looking around the table and having folks in different regions around the table, but using the same infrastructure in order to have a higher quality product. Kate?
Thank you, Keith. And last but not least, Ted Creamer from Rochester. Are you with us? I know you had some technical difficulties, but I think you're with us now.
Yes, I am, Kate. Thank you very much.
Wonderful.
So my name is Ted Creamer. I'm the Executive Director of the Rochester RIO. We were established as a nonprofit, as sort of a part of several regional care improvement efforts in 2006. And our mission was really to create a framework where patient information would really follow the patient. To that extent, we cover some 1.3 million patients across a 13-county area in Rochester and the Finger Lakes region of western New York. We currently provide sort of two fundamental service venues, if you will. We provide a results delivery and a patient-centric query service to almost 4,000 users across 400 organizations. The data is coming from some 70-plus organizations. On the results delivery side, we're currently supporting about 140 physician practices who are using one of 14 different electronic health record systems. So it's very similar to the direct model. On the query side of our business, we've done a good bit of patient outreach, communication, marketing to patients, consumers. So we've seen close to 500,000 patients consenting to their care providers to allow them to access the information through our RIO, because those query services do need consent for us. That consent rate, that positive consent rate, tends to hover around 97 to 98% of the patients say yes when their physicians ask them. In addition to the kind of traditional HIE data sources of hospital reports, transcribed reports, lab information, we also include radiology reports, radiology images as well. So we have a pretty robust radiology image exchange, medication information. But we also include somewhat less traditional care information because, again, we're trying to move to this very care-focused model. So we also include social service-based information based on elder care information and EMS information from our EMS providers. The other piece we've been moving on is providing consumer connectivity. That was something we heard early on, even when we started up. So we already provide consumer connectivity for patients to at least let them manage their consents, request audits online. They can also share advanced directives with their providers through our patient portal. And starting this summer, we'll be supporting two-way connectivity with personal health records. When we've built our business model, it's really based on funding from sort of two streams. There's funding from health plans, employers, and hospitals. But basically, two-thirds of the funding is coming from the employers and the health plans, and one-third of the funding is coming from the hospitals. And somewhat related to what Claudia was talking about, the funding and all of our sustainability was really predicated on meeting a series of very discrete performance benchmarks and providing our customers really specific dashboards demonstrating our operational transaction query volumes. So we really had to provide those sort of dashboards back to our customers. And what we end up doing is sort of setting our fees each year from those two different, employers and health plans and hospitals. But we set the fees just to sort of cover our operating expenses each year as a nonprofit. Works well for us. Moving forward, I think what we will see is a lot more patient connectivity. I think we've heard that everyone is looking at the analytical side of things. But with that, I think there'll be more conversations, Kate, where we all talk about what our futures will be. So that's sort of a snapshot of where we are today.
Thank you so much. And I think what we found is that we have a very diverse group of organizations that started in many different ways, but in some ways are evolving in the same direction ultimately, which is an interesting trend. So I'm going to throw out a discussion question or two and call on a few, but I'm also going to suggest that if any of our HIE leaders or colleagues in the room have pressing questions, we may have a chance to, go with one of yours as well. So I'm going to start with a theme. I know from our findings that a lot of you, I'd like to have a couple of you comment on your strategies related to consumer engagement. And I think, we've heard there's a wide range of approaches being taken, but I know this is something that's near and dear to the hearts of the NEHC board and certainly is a very important priority for ONC as well as many others across the country. So I guess I'm going to pick on Tom, since you haven't had to talk for a while.
Thanks, Kate. Consumer engagement's been a very important issue from us since the beginning, and I originally started with creating what we called the Inland Northwest Community Health Information Board, where we brought all of our key providers together and partners as well as consumers, educators, health plans, pharmacies, a number of other parties to really help drive with physicians kind of what was important at the point of care. Today we offer such things as, personal health records. We're doing a demonstration for the state of Washington on that. We are trying a lot of different ways to do things. We're even looking with mental health consumers about using phone applications for reminders on taking their medications and things that seem rather simple, but they're very, very important from a consumer perspective. We continue to convene consumer groups and solicit input to really try to make our system user-friendly and also meaningful to consumers. Clearly, having consumers at the table, I think, has been very, very important for us from the beginning, and I think you'll continue to see us very, very committed to bring the best thing that we can really from consumers and from their perspective, and especially with different consumer groups. We're definitely interested in the underserved consumer groups, and we also support a lot of community hospitals that are out in rural areas, so we're the lifeline for a lot of communities. We use telemedicine as well. We allow consumers and others to use that system, and we do a lot of things that really serve as a lifeline using technology as a way to really build that bridge.
Thanks, Tom. I think I'm going to ask Tim Cromwell to comment. I know the VA is such a leader in this area. Tim, do you want to make a few comments on patient engagement?
Sure, Kate. Thanks for the opportunity. One of the things I didn't mention is in VHA, we also have a very robust personal health record. It's called My Healthy Vet. We do in-person authentication to get the signature for the first time by veterans to be able to do certain things like secure messaging over the personal health record. We have a lot of contact with our veterans, and we're very confident that veterans want us to move toward health information exchange and interoperability with the private sector. We hear it anecdotally. We hear it, in a lot of different ways that veterans and veteran service organizations and groups want us to pursue. And because we are contacting every veteran, eventually we'll contact all 6 million of them to ask if they want to share their information with the Nationwide Health Information Network. We really have a very good relationship with our stakeholders, with veterans, with the veteran service organizations, in trying to get a sense of what they want us to do and what priorities. So in this particular project, in engagement with the Nationwide Health Information Network, in the pilots, we've already engaged in almost all of those 11 locations, a letter that goes out to the veteran explaining what it is we're asking them to do, sign this authorization. We've gotten some really good response rates from veterans who indicate that they're in favor of it. And just one very brief anecdote, our first pilot was in the San Diego area with Kaiser Permanente, and we sent out these authorization letters, the cover letters, and the authorization form asking for their signature on the day after Thanksgiving, and by Monday morning we had 100 of them back already. And so in certain markets and areas, we know that veterans want this, and that's, as I've said, that's pretty much our driver from our stakeholders to make this happen.
Thanks, Tim. I'm just going to ask for volunteers. Does anyone want to just comment on patient engagement?
Ted in Rochester, I think it's been very helpful for us. Again, we have two lines of business where we really had two sets of customers in some ways. We needed that patient to feel comfortable with providing consent to their physicians. So we early on engaged all our community PR people from the hospitals and created article banks and ad banks and did all household mailings and theater spots. And it's really helped, because otherwise physicians were very concerned that bringing patients up to understanding why they should participate in an HIE was going to sort of look like a long, uncompensated conversation. So I think it's absolutely critical, and there's creative ways to do it with your participants.
Thank you. Oh, Russ, go ahead.
Yeah, Kate, I was actually hoping you wouldn't call on me, and then as I sat here, I wanted to say something. So that's the risk you run. But just a couple of observations about this question. One, where we see a lot more patient engagement, and we talk about member engagement, right? Because if you think about our business, our primary constituents are health plans and physicians, yet they are serving patients, they're serving members, insured members. And through our network, we have roughly 100 million members that are served through physicians and health plans on our network. A couple of areas where we're seeing increased activity, right? So one is around the kinds of information that a patient needs to make a medical decision, right? So content and health plans, particularly trying to find ways to drive, patient-relevant content out to their members, condition-specific, disease-specific types of information. And then the other is around the financing side. Patient-centered medical home comes at the same time that you're seeing tremendous growth in high-deductible health plans, consumer-driven health plans. And one of the big challenges with those is providing transparency to us as consumers of healthcare around cost and quality, and where the alignment between those two exists. And so where we're being, I think, sort of uniquely challenged is to help our stakeholders, both physicians and health plans, drive that kind of transparency out to members, so that, at the point of service, and hopefully even in advance of the point of service, you're helping to drive educated decisions around healthcare. So just at a very rudimentary level, one of the capabilities that we've enabled for our physicians, and where we're seeing tremendous growth of activity, is real-time member estimation and payment for services. So, we know from the data that if a patient walks out the door without paying for their share of it, the shrink rate, the loss rate is 60%. On those dollars. And when that's a $10 copay walking out the door, it's not that big a deal. When it's a $200 member responsibility walking out the door 20 times a day, that adds up quickly. And so we're seeing both on the physician side, the plan side, as well as the patient side, a real interest in getting that information at the point of service, because just as physicians don't want to have to go collect all of this money. Patients really don't want to be bothered with it and, get bills for months at a time and try to figure out exactly how much they owe and what the health plan is going to cover. So, just as with our core business and serving the administrative needs of physicians and a real demand for more information around, eligibility and how our claims processed and, the basics, we're seeing a significantly growing interest in more member transparency and information around, frankly, from a physician perspective, how to interact with their patients from a financial perspective.
Thank you. So, we're kind of getting short on time, so I'm going to offer up one last sort of wrap-up question and try to call on as many of you as we can to get your words of wisdom. But this is a fabulous conversation. I know we'll have, we're going to make sure we have more opportunities to discuss. But so the wrap-up question is, if you had one opportunity, one word of advice to others who are, at an earlier stage in building their health information exchange organizations, what would that one, word of advice be? And I think I think I'll start with Alan from Big Bend.
Well, I think you quoted my word of advice in the press release, and that's basically keep going. It's most of us around the table, I would opine, largely do this out of passion to make change. And it's not about the money, it's about making a difference. And it is difficult, and it's going to be difficult for some time as we try to transition an industry of status quo into and across the digital age. But I've certainly wanted to walk away 3 or 4 or 5 times the last 6 years, but because we're now making some significant progress, we can see the change, we can see the benefit, we can see the adoption and the utilization. We are affecting positive change and saving lives. So keep going, and I actually can't take ownership of I'm saving lives. It was an ER physician that's a friend of mine when I was about to throw in the towel 4 years ago, looked at me very casually and said, "But you're saving lives." And, of course, my response was, "Don't do that to me." So keep it up and stick with it. We will get there.
Michael Matthews, how about you?
Well, thanks, Kate. It's been a good session. My advice would be to keep the focus on the patients, particularly the most vulnerable patients, the ones I mentioned in my remarks, the chronically ill, the emergency patients, wounded warriors, and the disabled. We have to get to a point in this country where health information exchange is viewed as a standard of care and not as something discretionary and optional. If we can get to that point, we'll figure out all the ways of sustainability and some of the other challenges that HIEs across the country have faced. Thank you.
Mark Jones?
Kate, thank you. I think I'd reiterate some of what our partners have said today, which is that starting at the bottom with the physician and the patient, focusing on that and trying to build your system up from the bottom is the key to success. I think we're seeing a lot of efforts around the country now at state levels where they're essentially starting at a very high level and trying to work down. And I hope that all of us here have active conversations with those groups so that the realities of what need to happen are reflected into the decision-making processes that they're going through right now.
Kimberly, how about you?
I think being sensitive to the different phases that organizations are at right now is really important, and to have product and service offerings that can meet those needs. Everyone's at radically different phases of EMR adoption, which is, kind of a base level that you need to be at. And I think, being open to offering the services. There are a lot of organizations that do not have the resources to do a lot of this. I think, being prepared to offer some of those services would be really crucial.
Keith Hepp?
This is our moonshot in healthcare IT. So there's significant funding that's out there in order to become electronic, and but very quickly it's going to go from lots of funds out there in order to build the infrastructure to how it's going to be sustained. So it is very hard work at the beginning to get a sense as to who's going to pay for what and why would they pay for it. But as you build your infrastructure, it's critical that you have a key understanding of the unique nature of who is participating in your exchange, who may participate in your exchange, and that when you build your infrastructure, that you don't build in such a way that initial participants are getting a sufficient value, but long term they do not get enough participation to get the value, so that you have tail costs, which will be very difficult to maintain. So starting off with a good plan, which involves a good understanding of what the economics of each of the different components of an exchange are, is critical to surviving past just the days of ARA.
John Blair, I'm going to give you the last word of wisdom.
Okay, so this is about HIEs and sustainability, right? So I think there's a couple of ways to look at this. If this is a community effort, then I think critical is leadership, and particularly outside of IDNs, and I think it's leadership and being able to galvanize a governance structure to drive that interest and ultimately build up HIE, et cetera. If it's really a business proposition, looking at what's going to happen with technology infrastructure across the country, clearly a lot of money has been put behind EHRs, and if it's successful, they should be fairly ubiquitous. And I think then there becomes a strategy of connecting those systems in a meaningful way clinically, and that's a different thing than the first thing I just said.
Okay, well, thank you so much. We are out of time, but I want to thank our HIE leaders for participating in this project, for participating in this discussion today. This is just the beginning of a lot more to follow. As I said earlier, NEHC will be releasing the report very, very soon, and we will also be building on the findings to do additional programs like this, both live programs and roundtable discussions, as well as web-based education programs that will both look at the case studies of these organizations, the critical success factors, go deeper on some of the remaining ongoing challenges out there, and try to come up with solutions to overcome them. So thank you so much, and thank you all for participating. This concludes the program.